And this is Inspired Afternoons with me, your host, Miriam Mia. And now we on to our Your Health is Your Wealth segment. And this segment is brought to you in the interests of good health by Path24 Laboratories. And I have with me Professor Shahed Omar, who is actually the head pathologist, chemical pathologist at Path24. But he's more than just a pathologist. Where did he get the time to specialize and specialize and specialize? Mashallah, I think when I first knew him, he was a GP studying register that time. Alhamdulillah, now he's a professor, and his current position is he's the head there at the intensive care unit at Krisbani, Kashani Baragwanath Hospital. He also is a professor in critical care, School of Clinical Medicine, University of Witwatersrand. So, Alhamdulillah, I'm so proud we have medical specialists, professors in South Africa that keep us in optimal health, that is well versed, especially in intensive care as well as in pathology. So let's welcome Professor Shahed. Assalamu alaikum wa rahmatullahi wa barakatuh. Shahed, and welcome to Inspired Afternoons on Salam Media.
Alaikum salam, Mariam. Jazakallah for the very generous and kind introduction. And assalamu alaikum to all our viewers out there. Inshallah, you're having a beautiful, blessed month of Ramadan. A special gift to all of us, this very special month.
So today we
And
Mhm.
yeah,
Go ahead.
and, yeah, no, and just thank you to our sponsors, Path24. Okay.
So today we're talking all about diabetes because it's an important topic, especially in Ramadan, with people who already have been diagnosed and have the condition of diabetes as well. They have to then change a lot of things in Ramadan and maybe alter medications. And sadly, some, depending on their conditions, are also unable to fast due to their diabetic conditions. So let's talk about it, but also let's start maybe at the beginning in terms of how often and how important. So let's start. Why do we need to talk about diabetes? I mean, it's become quite common now. Everybody's talking about it. I'm diabetic, or I have diabetes, or I need to go for a blood sugar test, or that. How big is a problem in South Africa with regard to diabetes?
Sure, diabetes is it's a real problem, not only in South Africa but globally. It's a growing pandemic, and with this modern lifestyle, it seems to be growing and growing. And in fact, in South Africa, if you think about it, we've only been able to maybe since 1985 we've been able to define it consistently. We've got proper definitions, so we've only started to appreciate what the problem is in the last few decades. And in fact, almost 1 in 10 South Africans, over the age of 15, so from adolescents upwards, actually have diabetes. And what's really scary about this is that almost half of them, or half of people living with diabetes, are unaware that they're diabetic, and this becomes a real problem from a complication perspective. But if you think about a group that's maybe more at risk, the older group, if you think about people above the age of 45, then I must tell you the statistics are even more scary. That's 1 in 4 people above the age of 45 will have an abnormality in their blood sugar. So that's a really startling statistic. We're facing a real big problem. And not only that, there's special groups in South Africa that are at very high risk. And our community, the Indian community, is at one of those very high risk groups. We have much higher risk of developing diabetes than other groups. And then the other group, obviously, is the mixed ancestry colored group that also share this high risk with us. So really, it's a big problem with lots of complications, often detected too late, even in this day and age. So really, I think this is something that we should highlight, and we need to continue highlighting as we go along.
So let's just start from the beginning. Yeah, we say diabetes, but what happens to your body? Or what
Okay.
happens to the body when somebody has diabetes? What goes wrong in the body in your very
Yes.
systems in that, because I always say this, and I spoke to Professor Karodia last week and said,
Yes.
sometimes the medical field is so vast. There are so many medical teams, terms, and things to know. And then you just nod your head when somebody tells you about a condition, because obviously you don't want to be called out. So you just act like you know what they're saying, what
Yeah.
happens. So let's do this. Let's educate everybody, especially for
Okay.
those who don't know what happens to the body if you are suffering
Good.
from diabetes.
Diabetes. Okay, so we're all familiar with sugar. We say we've got sugar. Okay, and really what that means, we've got high sugar, and that really is, in a sense, at the core of the problem. But why do we get this high sugar, or what we call hyperglycemia? Why do we get it? It's really a disorder of metabolism, how our bodies actually work, and usually what happens is our bodies produce insulin. Okay, and insulin usually affects the way our the carbohydrates and proteins and lipids are actually metabolized. And when either we don't have any insulin, or the insulin we have and doesn't actually, the body's prevented from actually working in the way that it should, okay, or having its action, we call it insulin resistance. When that happens, then the sugar rises, or the blood glucose rises, and then we say we've got hyperglycemia. And when this is ongoing, when it becomes chronic, okay, then this high sugar poisons the body. It actually, we say the sugar binds to things, but it actually poisons our nerves, our blood vessels, and it affects our eyes. We call it retinopathy, our kidneys, the nephropathy, our nerves. We call it the neuropathy, and it affects our hearts and blood vessels, and you get all these complications. So diabetes stems from what we would call a metabolic problem, and at the heart of the problem is this insulin that actually basically causes havoc, and causes our sugar to rise. And either because it's not there, or because it doesn't work. Okay, what we call insulin resistance. So here's a really nice picture, and you can actually see that on the left we've got normal glycemia. That's a normal glucose, and on the right we've got hyperglycemia. And it's actually a spectrum. As the sugar rises, okay, the problems occur. And at some point, when the sugar gets to a certain level, then we would say, and it stays there persistently, we would say, now you're diabetic. But remember, the complications start earlier, even in the phase that typically we would call. I'm sure a lot of people are aware of this term. We got pre-diabetes. Okay, so here when you have pre-diabetes, your blood glucose is not normal, okay, but it doesn't meet diabetes criteria, and you sit in this pre-diabetic area. And we as doctors, we call this an impaired fasting glucose, or an impaired glucose tolerance, and it's not well described, but even there's another test that we're going to talk about, the glycated hemoglobin, or the HbA1c, and that can also be abnormal. So it doesn't fall in the normal range. So, but the main thing I think is the sugar, or the glucose level, that starts rising. And this spectrum of rising obviously causes complications.
So, Shahid, what I need to ask you, you get type 1 diabetes or type 2 diabetes, and that, so that essentially, so diabetes is not uniform, right? You get different types of
Yes.
diabetes. Am I correct in my understanding of that?
Yes, absolutely. There's so many causes. Okay, obviously there's a common cause. We say type 2 diabetes is the most common cause. Maybe 90 or 95% of our diabetics are type 2 diabetics. Okay, but there are other causes, and type 1 and type 2 are the two main causes that we think about. And obviously diabetes in pregnancy, we call it gestational diabetes. So that's another important type of diabetes that we need to be aware of, because pregnant women are also at risk of diabetes, and we need to pick this up, because it affects not only them but also the unborn child. So we are aware of type 1, type 2, gestational diabetes, and then there are other types of diabetes that can result from chronic pancreatic disease, and other diseases that I think are important for doctors, maybe not so much for us now, because they will rule these out when they make the diagnosis. But essentially, if you want to think about it, type 1 occurs in childhood, okay, and it occurs very quickly, okay, and it's related to antibodies to insulin. So that's how type 1 works. Whereas type 2 occurs later in life, okay, and it's associated with a family history of diabetes, and the less frequently the antibodies, and more likely you have insulin resistance. Okay, so there is insulin, and in fact, early on the insulin levels may be quite high. Okay, but the insulin doesn't work doesn't work on at the tissue level, and we call this insulin resistance. And this type 2 diabetes is probably the most important one, and that's the one that's related or has many risk factors, including being overweight and having obesity and so on. So that's the one that's under a lot of scrutiny right now, and there's been lots of progress in managing type 2 diabetes in the last few years.
Okay, so let's go on to that question then regarding if there is a history of diabetes in the family, then are you at a greater risk? Do you need to get tested sooner? And should you get tested? And what red flags should we watch out for in terms when it comes to diabetes?
Okay, so very good. So look, if you look at our own South African guidelines, so if you don't have any problems, so let's see if you have got no problems and you're not aware of any problems, then the old guidelines were saying you should test yourself at 45. And in fact, these new American guidelines that came out last year, and I'm sure South African guidelines also would suggest a younger age. So they're starting at 35. But that's if you have nothing wrong with you, if there's no problem, okay, if you don't have any risk factors, okay, then you'd have a look at that time. But if you do have risk factors, okay, then you actually, at any age, you need to have yourself tested. So that's really important. And risk factors, you just need to have to be overweight, slightly overweight, and that's a BMI of over 25. So between 25 and 30, you don't even need to be obese. You don't need to meet the criteria for obesity. You just need to have be overweight and have one other risk factor. Say you've got hypertension or high blood pressure, or you have a sedentary job. You're sitting at a computer the whole day and you don't do much exercise, or you come from a high risk background like us. You might come from an Indian background or a colored background or mixed ancestry background. Then you've got risk factors, and then you need to have yourself screened. So that's
So you
very
say,
important.
okay, so you made a important point, especially so if you come from basically a traditional Indian background, is that a high risk factor for that? Is that population singled out as high risk for diabetes?
Yes, in fact, that population, together with the other mixed ancestry colored population, especially in the Western Cape, they have the highest burden of diabetes in our country. So much higher than the other race groups, black and white. So we definitely at the short end of the stick, and so we got to be more careful than others. But I must tell you that with the growing pandemic of obesity, I think more groups are starting to become at risk. So that's something we've got to be careful. But we are part of that. So we are high risk anyway. And then we're also part of this modern lifestyle, sedentary. We don't eat well, lots of processed foods, lots of carbohydrates. And that really puts us at extremely high risk.
So all the Polonis, Viennas, Russians, all that out of the window now. I think we need to become more aware of all the processed food. So what are we going to do? We're going to take a short break, and then I want to get into the screening and the testing. So who should get tested, and also what is the science behind this testing, because that is now your domain and expertise. So actually, when you get tested, what does it tell the clinician, and then what does a doctor read from those results? So let's do that after the break.
Salam Media, your spiritual companion this Ramadan.
You know, it's a wonder how kids get anything done these days. With all the distractions, when do they even get time to study? As a mother, all I can really do is make sure they have all they need to perform at their best. That's why I choose to include Sunfoil, triple refined pure sunflower oil with every meal I make. Naturally cholesterol-free and approved by the Heart and Stroke Foundation as part of a balanced eating plan. So whether I'm cooking, frying, or baking, I know every dish will be a wholesome one. Sunfoil, now we're cooking.
For the first time, I can dream again.
The Africa Muslims Agency Orphan Hope Program provides the food, clothing, and basic support needed by thousands of children across the world. Every child deserves a chance at a hopeful future.
For 50,000 trans, you can transform our lives with the AMA Orphan Hope Program.
Africa Muslims Agency, empowering, educating, inspiring.
The Prophet Muhammad, peace be upon him, said, "Use the black seed, for indeed it is a cure for every disease except death." This Ramadan, honor that guidance. Tip Black Seed supports your blood sugar during fasting, boosts immunity, sustains your energy from suhoor to iftar. Available at leading pharmacies. Tip Black Seed, your golden drop every day.
Elite Basmati, available throughout the Middle East and now for the very first time exclusive to South Africa. Brought to you by Murchison Spice, Pietermaritzburg's most famous specialty store. Elite Basmati, available in aromatic white and golden cellar, is packaged in a world-class facility in India and is filled with wholesome goodness for your well-being. Elite Basmati rice by Murchison Spice. For trade inquiries, contact Mohammed on 033 387 2121. Murchison Spice.
You are listening to Salam Media live from our headquarters in South Africa. This is Salam Media, keeping you company this Ramadan.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back, and you're in the company of Mu'alima Maryam Mia and Professor Shahed Omar, and we speaking all about diabetes. And when I think of diabetes, I just think sugar, stay away from sugar. And yeah, it sounds like the fun police, when you say diabetes, then you have to stop this sugar. And that's psychologically when you have sugar cravings, is when you have to stop the sugar. And such is life, that. So Shahed, let's talk about now the important thing, because, they say receiving a correct diagnosis, and then it's half your battle, because once you know what your ailment is, because if you're feeling offish and that, and even sometimes doctors check. Once you've got a confirmed diagnosis, then actually you are on the path to getting treatment and feeling better. So what does this treatment or screening of diabetes look like, and what do you do? And do you need only one test, or do you need a screening and then further tests to determine, really hone in on this? So let's talk about the pathology behind, am I using the right word? The pathology behind the testing and that. Okay.
Yeah. The testing behind everything. Okay, good. All right. So firstly, I just want to confirm with you that it's, when you say sugar, is keep away from sugar. It's easier said than done, right? It's all our favorite things have lots of sugar. So that's one thing. But so the testing that we do. So look, if patients have symptoms, then it's quite easy, because you've got symptoms. But say you don't have any symptoms, and then you're going to have a screening test done. And typically, then what we would do is we would do a fasting. So you need to fast for 8 hours, and then we do some blood tests. So we'll collect some bloods, and the first blood after the fast, the 8-hour fast, you'll have is a glucose test. Okay, so we call that a fasting glucose. So that's the first kind of test that you can actually have to screen for diabetes. Okay, and that tells us two things. If your level is 7 or more, then you've got, if you're asymptomatic, then you're highly likely to have diabetes. But then we need to confirm this. We need to confirm it by repeating this test, within a 2-week period on a second occasion. So if you don't have any symptoms and you have this, and you meet this criteria of this fasting glucose of 7 or more, then we'll probably call you back. You'll be counseled by a doctor, and he'll give you all sorts of lifestyle education, etc. You'll probably want to confirm this on a second occasion. However, if you've got symptoms, okay, and the important symptoms, you've probably heard of them. We call them the polys, the polyuria. You go frequently to pass water. you have polydipsia, you get excessively thirsty, you have polyphagia, you get excessively hungry, okay, and you may have other symptoms as well. But if you have these symptoms, and then you have a positive test, okay, then we actually can confirm that you have diabetes. So there is a difference between symptomatic and asymptomatic in the way we would actually make the diagnosis. Now that's one kind of test. Okay, the other kind of test that we do is what we call a glucose tolerance test. So a glucose tolerance test, basically it includes the first part of the test. So they'll also tell you that you got to fast for at least 8 hours, so no calories. Okay, and then you come in for a test, but you'll have to spend some time at the laboratory or at the doctor's rooms, because they will draw the first set of bloods, which is your fasting blood. Then you will get to drink a sugar drink. Okay, they give you a little glass, 250 mils, and they have 75 grams of glucose. So they give you a glucose drink, and then they do bloods. They repeat the blood at 2 hours. Okay, and then they check again. So now you've got two opportunities. You see if the initial fasting glucose is above 7 or more, then you are diabetic. That includes 7. And if the 2-hour test is 11.1 or more, then you're also diabetic. Okay, so it tells us, so we can say, yes, you're diabetic or not with these two tests. Okay, and then there's a third test that we have, and that's called the glycated hemoglobin, or what we know today as HbA1c. You'll see everybody does HbA1c testing. And that's a special kind of test. Okay, and that is given as a percentage, and if that value is above 6.4, so if it's 6.5 or higher, then you also have diabetes. So, and again, the repeats will be done if you're asymptomatic, and if you're symptomatic, then they will be confirmatory. So that's HbA1c. Now, why HbA1c? Why has this come up in this last two decades or so, or 3 decades? Is really because it's a special kind of test. It looks at how much sugar is actually, or glucose is actually bound. Remember last week we had Prof Karodia telling us about the red cell and hemoglobin. So it tells us about how much sugar is bound to the hemoglobin, how much glucose is bound to the hemoglobin. And the percentage, as it increases, it tells us not only about the diagnosis of diabetes, but it also helps us to tell us about how the glucose, how high or how the glucose was high for how long in this last, probably around 3 months, because the red blood cell has a half-life of around 90 to 120 days. So a lifespan of 90 to 120 days. So what happens is that you can tell not only about today, but you can tell in the last 90 days the sugar was high. So this presents a very nice treatment target, because it tells us about the control of your sugar in the last 3 months, more or less, or even 3 to 6 months. So HbA1c is a very good test, and it's one of the newer tests that have come up in addition to fasting glucose and oral glucose tolerance tests. Now, the glucose tests, the special thing about them is we take them, you'll see the tubes are a little different. They are gray top tube, a special type of tube, and that's just to stop the cells from using up the glucose once you put it into this tube. So one of the things your doctor will take this, it'll be a special tube, it'll be gray in color, and then you know he's taking it for the blood glucose. And when he does an HbA1c, then we need the cells, the red cells, because we want to look at the hemoglobin and how much glucose is bound to it. So then they will take a purple top tube, what we call an EDTA tube. Okay, so there's 2 different types of tubes, and often they will take both. Okay, so you'll have several ways to make this a diagnosis of diabetes. Okay, and remember that even if you don't meet the criteria for diabetes, that's a lovely slide. You can see there the criteria are there. above 7, and even if you don't meet them, you can see that in between meeting the criteria to say you're diabetic, and on the left hand side you say you don't have diabetes, you've excluded it. If your glucose is less than 5.6, if your 2-hour tolerance test is less than 7.8, and if your glycated hemoglobin is less than 6.5%, then it'll be you're not diabetic. But you can fall in between. And that's when you fall in between, that's when we say that you are pre-diabetic, and that's a risk factor. So if you're not diabetic and you don't have any risk factors, then you don't have to worry. You can come back even in 2 or 3 years, that's fine, and get tested and retest yourself, provided you haven't developed symptoms or anything in the interim. But if you have now fall in this pre-diabetic category, your doctor will probably now want to see you more frequently, at least once a year, but often even twice a year, to make sure that you don't go on to actually develop diabetes. And obviously, at this point, okay, a program for you, a lifestyle program, will actually already be started. And
So
sometimes,
that's what I wanted to ask you. That obviously, once you're diabetic, then there's going to be a certain course that you'll have to follow in certain treatment regimen, and like you've said, that last test you were saying that will be a very, very accurate determination in terms of how to go about. But if let's focus now, prevention is always better than cure. So I'd like to focus on this before, as a rounding off to round off that. If you're pre-diabetic, then obviously you'll need to make some changes in your lifestyle. I suppose exercise will be a very, very big part of the treatment regimen. So it's going to be a whole lifestyle change. So just tell me more or less, what, if you feel, what, I am a little overweight, we have a history of diabetes in the family, and I I am I have this inkling towards very, very sweet things, or maybe processed food and things like that. What would you give us advice, just that maybe somebody is pre-diabetic or can have a let's put it this way, predisposition towards diabetes? What would you give us advice now in terms of adopting a more wholesome, I won't say healthy, but more wholesome lifestyle?
lifestyle.
And can we end
Yes.
it with that?
Yeah. Okay. So I don't want to profess to be an expert in this area, because I work in an ICU where you fast asleep in ICU, okay, and and then I work with the bloods. So I'm not usually giving advice from this perspective, but I think what the guidelines would suggest is that probably one of the newest things that have come up today is weight loss. Weight loss is so important. Okay, so weight loss can actually stop the progression. Okay, and you can actually prevent. So if you're already pre-diabetic with appropriate weight loss, and the targets vary, they say 5 to 10%, and you can even lose more weight. But what you can do is you can actually reduce your risk of progression to diabetes by as much as 50%. So you can make a change in your risk progression just by that weight loss. And we obviously know that weight loss doesn't happen on its own. Weight loss, you've got to eat the right things, you've got to exercise. The kind of exercise you need to do is you need to do a high intensity exercise, at least 30 minutes a day for 5 days, and that's a brisk walk or cycling. You need to do some resistance training at least 2 to 3 times a week. Okay, and you need to change your diet from these processed carbohydrates to more grains and fruit, vegetables, and so on, and limit your sugar intake. So those, or even stop it totally, ideally. So you can definitely change your risk progression, okay, with those concepts. Now, obviously, those are broad concepts, and actually to carry them out, you actually do need to seek professional help. You need your doctor, a dietitian, and some assistant, probably from a sports physician or a sports somebody, a trainer or so on, just to get you on the show. Or you can get information from your doctor and to see what you can do. But definitely there are things you can do, and I've given you the broad principles, but there's a lot of detail. They always say the devil's in the detail, and the details in all of that. And obviously, but the point is that a lot can be done even before you start taking drugs. Okay, so that's
So
really
we're going to leave it at that. We run out of time. It was an interesting, informative discussion, and I'm so glad we spoke about the diagnostic part of it and what those tests, because I think sometimes it's just the thought of going to the test and what's going to be revealed. They say better you don't know or sit in your ignorant bliss, but it's not the case. Like I say, your health is your wealth. So Jazakallah for educating us on diabetes. And inshallah, we'd like to talk to you in the future as well, because there's another thing that I really, really would like to talk about is allergies and allergy testing and what does that entail, especially, a lot of people are now presenting with some form of allergy or the other. So I think it's important that, especially in kids as well, you know, I would like to get you on the show to discuss this, but you take care and may you continue having a spiritually uplifting and nourishing month of Ramadan. And this segment was brought to us and made possible by Path24 Laboratories. Visit their website on www.path24.co.za to check where is your nearest branch of Path24 Laboratories, and they have a cash docket. So for those of you that don't have medical aid or do not have sufficient benefits for these type of tests, there is a special cash docket that they have available as a service to the community. So with this, we say Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam.
We're going to go for short break.
Jazakallah for having me on the show.
Ameen.
Okay, assalamu alaikum to all the viewers too. Okay.
Wa alaikum salam. And that was Professor Shahed Omar. And now we're going to take a short break. And our last segment, I'll be speaking to the Chief Executive Officer, Yasmina Frankie of SANZEF. And they've been acknowledged with a recent award. And we're going to speak to all about that award and what does that award translate to for the donor. So all this after the break.